Step one in the cardiovascular risk world, I think, is to start with the guidelines. How is it possible that you have exactly the same evidence that's being reviewed by different experts and coming up with different recommendations? And I think the answer to that is that not all of these questions are resolved about, what's the optimal level of risk that we're trying to treat, and what's the optimal risk assessment calculator. We're not there yet. Blood pressure?
Always has been fine.
Okay.
No problems.
Meaning what? As a cardiologist, one of the things that I've been interested in for a long time, easily 25 years or more, is trying to understand how we define cardiovascular risk, how we identify people who are lower risk and might not require extensive treatment options versus people who are much higher risk and really deserve more intensive treatment options, including medication and other kinds of intervention. So this is up to 11 years of follow-up.
Okay.
And the interesting thing is that guideline after guideline has come to understand that there's a relatively small number of true risk factors that repeatedly, every time we look at them, are related to predicting risk. And many of those factors not only are useful in predicting risk, but they're also useful in identifying treatment targets. Broad recommendations are important for the population approach, but in the clinical approach, we want to target the intervention according to the patient's actual need. Which patients do I need to prescribe? Which patients don't I need to prescribe? And the problem is that it's often not that simple.
Findings from Dr. Greenland's research have been used to formulate risk reduction guidelines.
One of the areas that we've been very interested in our research is trying to understand not only the high risk end of the spectrum, but also the low risk end of the spectrum and what might be regarded as optimal risk factors. And the reason for that is that we think that there's evidence out there that if people are actually able to maintain optimal levels of risk factors, this not only lowers their risk, it almost eliminates their cardiovascular risk. A number of years ago, based on a lot of the research that we've done, the American Heart Association adopted a sort of a new category where they referred to it as ideal cardiovascular health. And the concept of the ideal cardiovascular health is really focusing people's attention on trying to keep the risk factors at optimal levels. Okay. What drug are you on?
Crestor.
Crestor, okay. And how much do you take, do you know? The obvious question is, are there more tests that I could do to improve risk assessment? And there are hundreds of them, and figuring out which ones are actually going to move the needle and which ones are just unnecessary, maybe even a distraction in the clinical setting has been, I think, a big question of medical research for easily the last 20, 30 years.
Studies show patients considered to be at low risk for atherosclerotic cardiovascular disease account for nearly a quarter of heart attacks and strokes, and as many as half of all deaths related to heart disease. Dr. Greenland and his colleagues are looking for more accurate ways to identify a patient's true risk.
We've often thought that we had the answer, that inflammatory markers, for example. We recognize that inflammation is part of the atherosclerotic process. But are the inflammatory markers that we can measure helpful in improving cardiovascular risk? And when you put CRP in most risk prediction models that include body weight, cigarette smoking, high blood pressure, diabetes, you move the needle a little bit, but not a lot, because those other risk factors already encapsulate much of the same information that you get from C-reactive protein. The one test that we've seen that's really moved the needle a lot is the coronary calcium measurement.
Researchers from the Framingham study found coronary artery calcium scoring was used to reclassify 1 out of 5 intermediate risk patients as high risk. Measuring other markers had failed to uncover the hidden danger they faced.
Part of the reason that the coronary calcium measurement really improves risk prediction a lot is that the hazard ratio, or the odds ratio associated with the high coronary calcium compared to a normal coronary calcium, which would be 0, is not, let's say, 2-fold higher or 3-fold higher, which some of these other risk factors are. It's about 10-fold higher. So, when you've got that huge increment in risk, now you're really talking about a test that can actually make a huge difference.
Join us next time for a discussion about the role of risk calculators in the clinical setting, the clues they provide, and the questions they leave unanswered.